When most people think about the human kidneys, they picture a simple plumbing system, right?
Right, like a series of pipes and filters.
Exactly. Just pipes, maybe a drain. You drink water, the pipes process it, and, well, the excess just goes out.
Yeah, it feels purely mechanical. Fluid in, fluid out.
But today, we are going to completely shatter that plumbing illusion. Because the kidneys aren't just pipes. They are a highly charged, exquisitely balanced electrical grid. So, welcome to the deep dive.
Thanks. It's a perfect topic for a deep dive, honestly.
Yeah, and today our mission is exploring loop diuretics, often known simply as the powerful water pills. We've got a whole stack of sources today: pharmacological history, clinical trial data, medical literature, and our goal is to understand exactly how these incredibly common drugs work.
And they are some of the most prescribed medications on the planet, especially heavily relied upon in acute care.
Right.
But the underlying pharmacology is deeply misunderstood, even in clinical settings. The delicate electrolyte balance they alter, the debates, it's all very complex.
Okay, let's unpack this. Because I can promise you, the listener, that by the end of this deep dive, you'll understand why these seemingly simple water pills are actually at the center of international sports scandals, complex eating disorders, and, surprisingly, climate-related health risks.
It really connects to everything.
It does. But to grasp all of that, we have to start at the very beginning. And the origins of this drug class is, frankly, terrifying.
Oh, yeah. The lineage begins with a medical accident in 1919 Vienna, and it involved a highly toxic heavy metal mercury.
Wait, mercury, not exactly a compound you want coursing through a patient's veins.
Not at all. So picture this physician, Alfred Vogel. He was treating a patient for syphilis using this organomercurial antimicrobial drug called novasterol.
Okay.
And this particular patient also happened to suffer from severe heart failure, which meant severe fluid overload.
So when Vogel administered this mercury-based injection, he noticed something totally unprecedented, right? The patient just began producing enormous volumes of urine.
Exactly. Vogel had accidentally discovered the potent diuretic effect of mercury compounds.
Which is wild, but it launched a deeply problematic era in medicine.
Oh, it was awful. Because these organomercurial diuretics, they had to be given by injection. The oral absorption was practically non-existent.
And worse, they caused intense kidney toxicity, right? Like dangerous, sometimes fatal heart arrhythmias.
Yeah, but for the next 3 decades, despite the clear nephrotoxicity, injecting patients with toxic mercury was literally the absolute mainstay treatment for severe fluid overload.
Treating heart failure fluid with mercury is like using a toxic sledgehammer to swat a fly. Sure, you get the desired result, but you destroy the house in the process.
That is a perfect way to put it.
So these modern loop diuretics were literally born out of a desperate need to stop poisoning people.
Pretty much, yeah. The medical community was frantic for a safer alternative, and that search eventually led to drugs called carbonic anhydrase inhibitors in the 1950s, and then a major breakthrough in 1958 with thiazides.
Right, specifically chlorothiazide, which was synthesized by chemists at Merck.
Exactly, and thiazides are still a massive part of modern hypertension treatment today.
But they offer comparatively modest potency, right? Like, they weren't strong enough for those really acute, severe cases of heart failure.
No, they weren't. So chemists recognized that limitation and just kept tinkering. In Germany, a chemist named Rudolf Muschweg was modifying that thiazide scaffold, and in 1962, he synthesized furosemide,
which reached the U.S. market in 1966 under a brand name almost everyone in healthcare recognizes: Lasix.
Yes, Lasix.
Which I love because it's a wonderfully literal contraction of last 6 hours, medical naming at its most practical.
It really is. But around that exact same time, like 1962 to 1963, a completely separate chemist named Edward Crago developed a drug called ethacrynic acid.
Okay, ethacrynic acid.
And this was the very first true loop diuretic to hit the market. Importantly, it wasn't built from the thiazide lineage at all. It came from research into agents that react with proteins in the kidney.
Got it. And then we later saw bumetanide in the early 80s and torsemide in 1993, which brought better oral absorption profiles.
Right, exactly.
Okay, so we finally have these incredibly potent, targeted drugs replacing toxic mercury. But how do we actually achieve that massive fluid shift without the heavy metal poisoning? What is the specific cellular target here?
Well, to see that, we have to zoom in microscopically on the kidney. specifically a structure called the Loop of Henle.
Hence the name, loop diuretics.
Right. So imagine a microscopic tube dipping deep into the kidney tissue and then coming back up. The part coming back up is called the thick ascending limb.
The thick ascending limb, got it.
This segment is an absolute workhorse. It reabsorbs roughly 25% of all the sodium the kidney filters. And it accomplishes this using a highly specific cellular doorway, a transporter called NKCC2.
NKCC2. Okay, so it acts a bit like a highly specific bouncer at a club?
Yeah, that's a good analogy. It grabs one sodium ion, one potassium ion, and two chloride ions from the tubular fluid and pulls them all back into the body's cells simultaneously.
Wow, all four at once.
Yep, and loop diuretics like fucosemide, they bind directly to this transporter and just lock it down.
So, shutting down a segment that handles a massive 25% of all the body's sodium, I mean, that means all that sodium stays trapped in the tubular fluid, right? Pulling a huge amount of water with it via osmosis.
Exactly. And the segments of the kidney further down the line, they simply cannot compensate for that sheer volume of escaping sodium.
But there's more to it than just sodium, right?
Yeah. What's fascinating here is that the thick ascending limb is doing something much more subtle than just moving sodium. This is where we leave the plumbing analogy behind and get into the electrical grid.
Okay, lay the electrical groundwork for me. How does that work?
Remember how NKCC2 pulled in a potassium ion? Well, the cell doesn't actually keep all that potassium. It recycles some of it, leaking it back out into the tubular fluid through a channel called ROMAK.
Wait, but potassium is positively charged. So leaking a positively charged ion back out into the fluid would alter the entire electrical environment.
Exactly. It creates a strong positive electrical charge inside the fluid of the tube, what we call a lumen-positive electrical gradient. And since positive repels positive, this charge actively pushes other positively charged minerals out of the fluid, forcing them between the cells and back into the bloodstream. It literally acts as an electrical force field driving calcium and magnesium reabsorption.
Oh, wow. It's like pulling a single Jenga block, the NKCC2 transporter, and watching the entire electrical gradient of the kidney just collapse, taking calcium and magnesium down with it.
That's exactly what happens. When you give a loop diuretic, you shut down NKCC2. Potassium stops coming in, which means it stops recycling back out through ROMK.
So the positive charge vanishes.
Yep, the electrical force field collapses.
Suddenly the calcium and magnesium have nothing pushing them back into the body. They just wash away.
Right. The patient loses potassium, magnesium, and calcium. They develop hypokalemia, hypomagnesemia, and hypocalcemia. The calcium is wasted into the urine, which drives a state of hypercalciuria.
Which is wild because that is the exact mirror image of how thiazide diuretics work further downstream.
Right. It is. Thiazides target a totally different segment, the distal convoluted tubule, and they actually increase calcium reabsorption. They cause mild hypercalcemia.
So they hold on to the calcium instead of dumping it.
Right, and medical students constantly mix the two up. But there is a classic vital exam rule to keep it straight. Loops lose calcium, thiazides keep it.
Loops lose, thiazides keep. That's catchy. But since these drugs completely disrupt this fundamental electrical gradient, you'd think early physicians understood exactly what they were doing at the cellular level.
You would think so, but no. Early on, they categorized these drugs based on their chemical shape, not their actual electrical effect.
And that leads to one of the most pervasive, dangerous clinical myths in medicine, doesn't it? The sulfa allergy myth. Walk us through this chemical illusion.
So for decades, clinicians grouped furosemide, bumetanide, and torsemide together because chemically they share a sulfonamide moiety, which is just a structural piece inherited from earlier drugs.
Okay, a sulfonamide piece.
Right. And there is a very common class of antibiotics called sulfonamides like trimethoprim sulfamethoxazole, and patients frequently have severe allergic reactions to them.
Oh, yeah. A sulfa allergy. You see it flagged in bright red on medical charts everywhere.
Exactly. So the assumption was that if a patient is allergic to a sulfa antibiotic and furosemide has a sulfa piece in its chemical structure, a cross-reactive allergic reaction is just guaranteed.
Wow, so doctors would needlessly withhold these life-saving, fluid-clearing drugs from patients who were essentially drowning in their own pulmonary edema.
Yes, out of fear of causing an allergic reaction.
Here's where it gets really interesting, though. Pharmacological review has largely dismantled this fear. Right.
Entirely.
Because the allergic reaction to antibiotic sulfonamides is tied to a very specific structural feature and arylamine group at the N4 position.
And loop diuretics completely lack that arylamine group. Actual cross-reactivity is incredibly rare. The historical data that suggested a link mostly just captured patients who were prone to allergic reactions in general, not an allergy to a shared structure.
It's just guilt by association. And the modern pharmacologically correct definition of a loop diuretic abandons chemistry altogether anyway. If it blocks NKCC2, it's a loop diuretic.
Right. I mean, ethacrynic acid, that drug from 1962, doesn't even have a sulfonamide group at all, but it is functionally identical in how to attack that transporter.
But since early doctors were treating these distinct chemical keys as if they were identical, they also made incredibly dangerous assumptions about dosage, right?
Oh, massive assumptions. Assuming that 40 milligrams of one loop diuretic is the same as 40 milligrams of another is a really well-documented source of hospital medication errors.
Because these drugs are absolutely not dose equivalent. The clinical conversion from the sources is stark. 40 milligrams of furosemide equals about 20 milligrams of torsemide, which equals just 1 milligram of bumetanide.
Yeah, so attempting to swap them one for one during a hospital transfer could massively overdose or underdose a patient.
Wait, I'm stuck here. Let's say we have the math right. If the modern definition abandons chemistry for the actual site of action, how do doctors manage a patient when the correct drug stops working? Like, my first instinct in almost any other branch of medicine would be to just increase the dose.
That's a natural instinct, but with loop diuretics, they have a steep sigmoidal dose-response curve with a hard ceiling dose.
Okay, a ceiling dose. Why wouldn't pushing past that ceiling force more sodium out? And doesn't that just invite toxicity? I've read that giving massive doses actually attacks the patient's hearing.
You've hit on a critical limitation and a severe risk. Below a certain threshold on that sigmoidal curve, nothing happens. But once you hit the ceiling dose, the NKCC2 transporters in the kidney are fully saturated.
So they literally can't work any harder.
Exactly. Giving more drug cannot force out more sodium, but it can cause profound harm, specifically ototoxicity, hearing loss.
Because the inner ear uses a nearly identical transporter system, right?
Yes. A variation of the transporter, called NKCC1, maintains the delicate ion balance in the endolymph of the inner ear. If you push a loop diuretic too fast through an IV, or use massive doses trying to break through that ceiling, the drug spills over and binds to NKCC1.
Oh, wow.
You disrupt the inner ear and can literally cause deafness.
Wait, so if a patient isn't getting better, the natural human instinct is just to give a higher dose?
Yeah.
But you're saying there's a literal ceiling, and pushing past it doesn't help the kidneys, it just risks making the patient go deaf.
Unfortunately, yes. And ethacrynic acid actually carries the highest risk of this ototoxicity, which is why it's basically relegated to a last resort for patients with the severe, genuine hypersensitivity to the other options.
That's terrifying. But beyond the ceiling dose, there is a mechanical limitation called diuretic braking that further complicates things.
Yeah, diuretic braking is fascinating. If you use a loop diuretic chronically, you are constantly dumping extra sodium into the fluid that flows downstream. And the segment of the kidney just past the loop, the distal convoluted tubule, notices this massive sodium load.
Let me guess. It adapts.
It literally hypertrophies. The cells grow larger and stronger to reabsorb the escaping sodium, actively blunting the diuretic's long-term effect.
But why would the kidney actively fight the drug by building a bigger net downstream? That seems so counterproductive when the body's in heart failure.
Well, evolutionarily, the kidney is designed to protect blood volume at all costs. It interprets the massive sodium loss not as a helpful medical intervention, but as a severe threat of dehydration. So it beefs up its downstream defenses.
Wow. Okay, so we can't just give more loop diuretic because of the ceiling dose and the hearing loss risk. So what is the clinical workaround when the kidney puts on the brakes?
They use a strategy called sequential nephron blockade. You add a second drug, a thiazide, like metolazone. By giving the thiazide, you block that newly hypertrophied downstream segment. You block the loop, and you block the kidney's backup system simultaneously.
Okay, that makes sense. But getting the drug into the system to block those targets can be surprisingly tricky depending on the specific pill, right? Furosemide has notoriously erratic oral bioavailability.
It really does. If a patient takes a furosemide pill, anywhere from 10% to 100% of it might actually make it into their bloodstream.
Wait, 10 to 100%?
Yeah. In severe heart failure, the wall of the gut becomes swollen with fluid, and that physically impairs the absorption of the drug into the capillaries.
A 10 to 100% variance is massive. You basically have no idea how much functional drug the patient is getting day to day.
Exactly. This is why torsemide and bumetanide are increasingly preferred. In tricky cases, they have much more consistent absorption profiles. Torsemide is roughly 80 to 100% bioavailable regardless of gut edema.
Oh, that's much better.
Yeah, the TORC study in 2002 even found a suggestive trend toward better outcomes and fewer hospitalizations with torsemide compared to furosemide, likely driven by that predictability.
But when a patient is in acute respiratory distress in the hospital, they aren't taking pills anyway. They're getting intravenous doses. And cardiologists debated for years over the best way to administer the furosemide in acute heart failure.
They did, until the landmark dose trial in 2011 settled a lot of that debate. They looked at bolus injections versus a continuous drip and a low dose versus a high dose strategy.
And the high-dose strategy resulted in greater fluid loss and better relief of symptoms like shortness of breath.
Right.
It did cause a temporary reversible rise in creatinine, which is a primary marker of kidney function. But there was no significant difference in the trial's primary overall outcomes.
Which was a big deal because historically a rise in creatinine usually panicked doctors. A rise in creatinine meant potential kidney injury, so the reflex was to immediately back off the diuretic.
So how do we know the creatinine bump isn't actually destroying the kidney tissue?
Well, trials growing out of the ESCAPE study fundamentally challenged this reflex. They demonstrated that this modest creatinine bump during aggressive fluid removal often just reflects hemoconcentration.
Meaning, as you aggressively remove pure water from the bloodstream via the kidneys, the total volume of blood shrinks. The amount of creatinine in the blood stays the same, but it's now concentrated in a smaller pool of liquid, making the lab value look artificially high.
Exactly. It's an illusion of concentration, not actual cellular damage. It might even mark a highly effective clinical response, though this remains a fiercely debated topic in cardiology regarding the management of cardiorenal syndrome.
So we have all these incredibly complex microscopic battles happening in hospital beds, ceilings breaking, hemoconcentration. But how does this impact you, the listener, and the wider world? Because these biological levers don't just exist in a vacuum.
They don't. And if we connect this to the bigger picture, we really have to start with a sobering reality check from the sources. Loop diuretics are the most commonly prescribed drug class for heart failure globally. Yet, unlike ACE inhibitors or beta blockers, no loop diuretic has ever been shown in a randomized trial to reduce mortality.
Wait, really? They don't extend life?
No, they don't. They are incredibly effective at relieving congestion and symptoms. They clear the fluid so the patient can breathe, but they do not treat the underlying disease process of the failing heart muscle. They're actually among the least disease-modifying cardiovascular drugs we have.
But because they are generic and cheap, millions of people take them daily, which creates a very modern, real-world risk at the intersection of pharmacology and climate change.
It does. Think about elderly patients on a chronic daily dose of furosemide. When a severe heat wave hits, they are at extreme risk.
Because of dehydration.
Exactly. Heat causes rapid, insensible fluid loss through sweat, and that compounds the effects of a drug that is actively forcing the kidneys to dump sodium, potassium, and fluid volume. It is a dangerous, rapid compounding effect leading to severe dehydration and electrolyte collapse.
And moving from climate to culture, loop diuretics show up in the sports world too. The World Anti-Doping Agency, WID, strictly bans them.
Right, but not because they enhance performance. Draining your blood volume certainly won't make you run faster or jump higher.
No, they're masking agents. Athletes use them to rapidly flush massive amounts of highly dilute urine to hide the presence of other banned performance-enhancing substances.
Exactly.
Or they are abused in combat sports and rowing for extreme, rapid weight cuts, draining water weight to squeeze into a lower weight class, a practice that has literally led to fatal cardiac events.
It's extremely dangerous. And that extreme non-medical use brings us to a really difficult psychiatric intersection as well. In severe eating disorders, covert abuse of loop diuretics for weight control is something clinicians actively have to screen for, as it creates a massive diagnostic dilemma.
Right, because chronic loop diuretic abuse perfectly mimics a rare genetic condition called Bartter syndrome.
Yes. Bartter syndrome is an inherited mutation in those exact transporters we discussed earlier, NKCC2 or RMK. A patient with Bartter syndrome inherently leaks potassium and calcium, presenting with hypokalemia, metabolic alkalosis, and hypercalciuria.
So functionally, having this genetic mutation is identical to taking a high-dose loop diuretic every single day.
Identical. A clinician sees a patient with these deeply skewed, life-threatening electrolytes, and they have to figure out, is this a rare genetic mutation, or is this covert drug abuse driven by an eating disorder? They often have to run complex urine toxicology screens for diuretics just to solve the puzzle. And as a physiological side note, there is a similar condition called Gitelman syndrome, which involves a mutation in the thiazide transporter downstream. It perfectly mimics chronic thiazide use rather than loop diuretics.
So what does this all mean? We started with toxic mercury injections in 1919 Vienna, and we've navigated through the microscopic electrical force fields of the thick ascending limb. We've seen how the kidney fights back by building bigger cellular nets downstream. We've debunked the sulfa allergy illusion, and we've explored how a generic water pill intersects with global heat waves, sports doping, and profound diagnostic mysteries.
It just highlights that there's no such thing as a simple medication. Every drug is a key that unlocks a very specific biological door with cascading systemic consequences.
Absolutely. Thank you so much for joining us on this deep dive. But before we go, I want to leave you, the listener, with one final provocative thought built on the source material. We talked about how loop diuretics disrupt normal mechanisms, but they specifically obliterate something called the countercurrent multiplication mechanism in the renal medulla.
Right, which is a system deeply tied to ADH antidiuretic hormone or vasopressin.
Exactly. What that means mechanically is that loop diuretics destroy the kidney's ability to concentrate urine. They force the kidneys to pump out perfectly dilute fluid, regardless of what the rest of the body desperately needs. Imagine this: if you were ever stranded in a desert without water and you took a loop diuretic, it wouldn't just make you pee.
No, it'd be much worse.
It would actively force your body to flush out the pure, clear water it requires to survive, entirely bypassing your brain's hormonal signals to conserve moisture. The drug acts as a biological self-destruct button in a survival scenario.
Literally overriding millions of years of evolutionary water conservation in a matter of minutes.
It's not just a plumbing system. It's a high-stakes electrogrid. Something to ponder the next time you hear someone casually mention taking a simple water pill.